the hypermetabolic state, which can be altered by nutrition, improving the nutrition, is major surgery or major injury and infection. So overview of surgery, there was a, now the surgery has become an integral part of our global care. So around 234 million operations are done yearly globally, and most commonly done surgeries are abdominal surgeries, as it accounts for around 29% of the total surgical operations, or total operations done in an year, while in females, obstetric and gynecological procedures are more than the abdominal surgeries. Other surgeries which are more common are cardiovascular, ophthalmic, orthopedic, and head and neck surgeries. So this was from an epidemiological study done from East Delhi in 2011. So what does malnutrition do in patients who undergo surgery? 50% of the hospitalized patients which come for surgery or admission in the hospital are malnourished, as per data from India. And what makes them more prone for malnutrition is that before surgery, most of the patients decrease their oral intake, maybe because of the effect of infection, effect of malignancy, or some problems like decrease intestinal absorption, decrease in intestinal movements, or there is some obstruction, or there is some pre-existing chronic disease. So these all are causes which lead to malnutrition in patients who are admitted to the hospital. And what are the side effects? As Dr. Ashish already stated, that most important in the post-operative period is wound dehiscence, poor healing, and breakdown of surgical anastomosis, especially in abdominal surgeries, and poor immune response to infection in these patients, causing severe sepsis and increased ICU stay and increased hospital stay. And how does this happen is because surgery is itself an acute stress, and it induces a catabolic state in which cytokines are released from the injury site, and they affect the hormonal and the natural milieu of the body. There is release of cortisol, glucagon, and growth hormone, which all leads to glycogenolysis and gluconeogenesis, and which ultimately leads to hyperglycemia, state of insulin resistance, increased chances of infection, lipolysis and protein breakdown, leading to muscle atrophy and ketone body production, and there is always loss of lean body mass. So all these leads to increase in the effects of malnutrition and affect the immunological status of the patient as well. So what we need to do in all these cases, we need to optimally nutrition these patients. Optimal nutrition is very important. And what does it mean? It means we should not go for underfeeding or overfeeding, because underfeeding will cause a precipitous decline in the nutritional status, while overfeeding can lead to hypercapnia, metabolic acidosis, again hyperglycemia. Again, the same cycle goes on, affecting the immune response and the catabolic state of the patient. So, as Dr. Ashish already stated, there are various ways to assess this nutritional status. I will not repeat all those things, but what is important in our setup, which we can do very easily, is serum albumin level. And this has been accepted by most of the surgeons worldwide, that serum albumin level is one of the very important indicator of nutritional status, with the caveat that it has falsely low values in presence of infection. So it has been found that patients who have serum albumin of more than 4.5 usually have a 30-day mortality post-surgery of less than 1%, while those with serum albumin level of less than 2, the mortality goes above 30%. So the albumin level is a good indicator in patient for nutritional status, and most acceptable albumin level for any surgeon is around 3. If the albumin level is above 3, the patient usually falls in a safe zone. Now, how do you calculate how much energy to give in all malnutrition patients? So there is a Harris-Benedict equation for estimation of resting energy expenditure. So we add stress factor to that. In presence of minor surgery, the stress factor is 1.1, while in presence of major surgery, the stress factor is 1.2. Apart from that, there are various activity factors, that if the patient is confined to bed or is out of bed, or is normal and healthy activity is going on. So according to that, we add stress factors and give energy accordingly. And one more important thing is for rising body temperature. For every degree rise in body temperature above 37 degrees Celsius, the stress factor which is added is 0.1 above to whatever is required for the patient. Well, if we go in a simple method, then it is around 25 to 30 calories for normal individuals. For moderate illness and minor injury or minor surgery, it is around 30 to 35 kilocalories per kg per day. While for critical illness, it goes on to 35 to 40 kilocalories per kg per day. Now, what are the criteria to initiate perioperative nutritional support? It was very well covered by Dr. Ashish. I'll delineate one of the few of the important points. And one most important aspect is past medical history. That is, if the patient was in severe undernutrition or there is evidence of chronic disease, then these patients do require nutritional support. And another important is involuntary weight loss of more than 10 to 15% of usual body weight within 6 months, or more than 5% within 1 month. That is, the significant weight loss is present in history, then these patients definitely require perioperative nutritional support. Another important aspects are if the expected blood loss is more than 500 ml, weight of 20% under the ideal body weight, or the BMI is less than 18.5 kg per meter square, then these patients should be subjected to perioperative nutrition support. Again, failure to thrive in pediatric patients and decreased developmental curve or serum albumin level less than 3, and anticipated that the patient will be in inanition for more than 7 to 10 days in the perioperative period, or there is severe burn or severe trauma, then these patients do need nutritional support in the perioperative period. Now, what are the routes of administering the nutrition? So one of the most important, most common route is use the oral route if it is available. And if there is any contraindication to oral feeding, then we resort to other routes like nutrition by the enteral route or nutrition by the parenteral route. So if the principle is at least 20% of the calories and protein requirement should be given enterally, if possible. If it is possible to give 100% enterally, it is very good. If not, then at least 20 to 30% of the calorie and protein requirement should be administered enterally. And additionally, we can give parenteral nutrition to achieve the nutritional growth. And the parenteral nutrition should be given till the patient is able to tolerate 75% of calories through enteral or oral route. And we should maintain enteral nutrition until the patient is able to tolerate 75% of the calories through oral route. So switching over is also defined, and when to and how to give this nutrition support is also very well defined. Now coming to the various routes of administration, so administration of feed. So first I will be covering the enteral nutrition. So enteral nutrition is either given through nasogastric or nasoduodenal or nasojejunal tube, or through a feeding gastrostomy or a feeding jejunostomy. The difference is that NG or NJ tube is placed nasally, and the gastrostomy or the feeding jejunostomy tube is placed percutaneously, and that too surgically or endoscopically. So if the patient is expected to require feed administration for less than 4 weeks, then nasojejunal tube is very well accepted. And if the feeding is required or expected to be going on for more than 4 weeks, then a feeding gastrostomy or feeding jejunostomy should be done. This is especially done in patients like a patient with a carcinoma esophagus, or a patient with a oral malignancy, or a patient with a corrosive injury of the esophagus or stomach, who is likely to require prolonged nutrition before undergoing a definitive surgery, should definitely undergo a feeding gastrostomy or feeding jejunostomy. Now, there was a big debate on whether, if required through a nasojejunal or nasogastric tube, which is better. So there were various trials comparing the NG versus NJ feeding, and they found that there is absolutely no difference in the incidence of pneumonia or time to ventilator or length of ICU stay, whether you give NJ or NG tube. So both of them are equally accepted if the duration of feeding is less than 4 weeks. Now, what are the advantages of enteral nutrition? So, enteral nutrition, apart from delivering the nutrients to the body, it stimulates enteric blood flow. It improves the barrier function of the gut and prevents bacterial translocation. It also provides fuel to the colonocytes through free fatty acids and avoids colonic disuse and diffuse colitis, and it improves the gut, and it increases the gut motility and decreases the ileus of the patient. And as well as enteral nutrition is always cheaper and easy to manage as compared to the parenteral nutrition. So as I already said that enteral nutrition can be given through gastric route or a jejunal route. So if you are using a gastric feeding, then the feed can be hypertonic or isotonic, and it can be given in bolus, or it can be given as a continuous infusion. While when we are using a jejunal feeding, then the feed should always be isotonic or sometimes hypotonic, while infusion rate has to be continuous. It cannot be given as a bolus feed. And when we are initiating the feed, then the feed rate should be around 25 to 30 ml per hour, followed by daily increments of around 20 to 30 ml per hour daily to 100 to 150 ml per hour in a day. Now, when it is the problems are that if gastric feed is not given in a proper method, then it may lead to intolerance, which may present as vomiting. While if jejunal feed is in excess of what can be tolerated, it leads to distension, diarrhea, and reflux. So, coming to various types of enteral formulas which can be given. The most common and most easily available is low residue isotonic formulas which can be prepared at home, and the calorie density is usually 1 kilocalorie per ml, and it contains no fiber, no bulk, and no residue, and it is cheap. It is the first line for stable gastrointestinal tract if we are choosing the enteral route. Other formulas which are available are elemental formula. When there is difficulty in digestion or absorption, then usually pre-digested nutrients are given. But the problem with these is that they are poor in fat and vitamin and trace elements, as well as they have a high osmolarity, and they are very high in cost. So elemental formulas are not very much encouraged, especially in patients who can tolerate isotonic formulas, that is hospital churn diet or the curd-based diet. Other immune enhancing formulas have been described like glutamine, arginine, omega-3 fatty acids, nucleotides, and beta carotene, which have been studied over the years, and I will be discussing on them at the end of my presentation. Now, coming to how to monitor when we are giving enteral feeds. So, especially in patients who are in acute phase or in toxic phase, if we are giving enteral feeding to them, then in immediate post-operative period, then electrolytes and complete blood count should be done daily. The glucose level should be checked regularly. Apart from that, the creatinine level, the input-output, body weight should be checked regularly in all these patients. While in stable patients like short bowel syndrome patients or patients requiring prolonged enteral feeds, these things can be done with a bigger gap of around 1 to 2 times per week for electrolytes and complete blood count, while the input output can also be measured 2 to 3 times in a week. And urine output should always be measured in all these patients on a regular basis every day. Now, what are the complications associated with enteral feeding? So, if we are using a nasojejunal or a nasogastric tube, then chances of epistaxis and sinusitis can affect the patient. If we are using a feeding gastrostomy or feeding jejunostomy, that is to the percutaneous food, then tube malpositioning or dislodgement can be a problem, or there can be leak from the gastrostomy or jejunostomy site causing peritonitis and all. Apart from that, if we are not not monitoring the feeds nicely, or we are not adhering to the instruction of the doctors or nursing staff, then excess of feeding can cause diarrhea, resulting in dehydration and disturbance. Apart from that, if we are giving a nasojejunal or a nasogastric tube, then in unconscious patients, the chances of aspiration pneumonia is high. Another problem with all these enteral feeds or any parenteral feed is refeeding syndrome. I think this will be very well covered in a coming lecture by Dr. Anupam, I feel, as far as I remember. And so I will be just touching on refeeding syndrome. It actually is caused by acute. It is caused by increase high amount of feeds given to a patient on the first go when the patient is in inanition or malnutrition for a long time, and we straight away start with 1000 2000 calories of feed for the first day, then that results in fatal shifts in fluid and electrolytes because of hyperglycemia, and that may result in hypophosphatemia, various forms of electrolyte disbalance. The most common is hypophosphatemia, hypokalemia, hyponatremia, hypomagnesemia, and thiamine deficiency, and this can lead to fatal consequences as well. So refeeding syndrome should be avoided. I will just cover in which the salient points on refeeding syndrome. So it should be the risk factors include body mass index of less than 16, or unintentional weight loss of more than 50% in the past 3 to 6 months, or little or no nutritional intake for more than 10 days, and low levels of potassium, phosphate, or magnesium before feeding. So in all these patients, we should be careful when we are instating the feeds. So what are the factors we should take care of? First of all, we should administer thiamine to all these patients. We should start feed at the rate of 0.0418 megajoule per kg per day. That amounts to around 10 kilocalories per kg per day. So if a patient is around 30 to 40 kg, which usually a malnutrition patient, a patient with malnutrition will present with, you should not give more than 300 to 400 calories per kg per day on the first day, and slowly increase the feeding over 4 to 5 7 days to a level of 40 to 50 calories per kg per day. So this is very much important to identify and preemptively treat all these patients who are prone to develop refeeding syndrome. Now, what are the contraindications to enteral nutrition? So it includes intractable vomiting or diarrhea refractory to medical management, paralytic ileus, distal high output intestinal fistula, GI obstruction, or GI ischemia is there. If the patient is having diffuse peritonitis, or the patient is in severe shock or hemodynamic instability, then enteral nutrition cannot be instated. Other contraindications include severe GI hemorrhage or short bowel syndrome, that is small bowel which is left with the patient is less than 100 centimeters, severe GI malabsorption, or inability to gain an access to the GI tract. So in all these patients, we resort to parenteral nutrition. Parenteral nutrition can be given centrally or peripherally. So for the patients who have malnutrition cannot be given enteral nutrition, parenteral nutrition is the answer. The advantages are that it is potentially life-saving when GI tract is not functional, and disadvantages are that it is costly, it has long-term risks of liver dysfunction, kidney dysfunction, and nutrient deficiency, and as well as access site infection. So indications for TPN are similar as contraindications of enteral nutrition. So I'll not be repeating all those factors. So most important factor is if the enteral nutrition cannot be given, it forms an indication for a total parenteral nutrition. Now, as I stated, it can be central parenteral nutrition or a peripheral parenteral nutrition. So central parenteral nutrition is given to a central vein, and it is a preferred route, and it can deliver daily requirements of kilocalories, proteins, and macronutrients in a concentrated volume. While another way of giving central nutrition is through peripherally inserted central cannula. So this has an access to the central vein and avoids the in problems with peripheral nutrition and the peripheral problems with a central nutrition, that is centrally inserted cannula, causing more chances of bloodstream infection. So PICC line has low chances of phlebitis, can accommodate hypertonic fluids, and it is easier to insert than a central line. Now, what a TPN solution contains? It contains dextrose. Most common concentrations are 25 to 50%, and sometimes 70% of dextrose. Protein amino acids are there, concentrations fall in 8.5 to 15%, and lipid emulsion, either it is 10% or 20% lipids, which forms a concentrated source of kilocalories. All these together give it forms a source of around 1 to 1.5 kilocalories per ml infusion. Now, how does lipids help? Lipids help to prevent the respiratory acidosis, because lipids have produced less of carbon dioxide, uh, giving more of while giving more of nutrition, because the as compared to carbohydrates, and it needs at least 10% of all the feeds which we give should contain at least 10% of essential fatty acids, which can be delivered only by lipid emulsion. Excessive lipid administration may suppress immune function, so it should not exceed 10 to 20% of the total energy intake. While lipids also form a potential source of vitamin K and other fat-soluble vitamins, which can help to improve the coagulation profile. Now, TPN solution also contains vitamins for you know for daily multivitamin formula, which should be given. It contains electrolytes also, and we have to adjust as per needed. We should give electrolytes apart from what TPN can deliver by regular monitoring. And other common medications which will be required along with TPN will be insulin, heparin, maybe to avoid coagulation of the catheters, and phlebitis, as well as, in addition to that, either PPIs or the PPIs, that is to prevent the development of stress ulcers in the stomach. Now, peripheral parenteral nutrition is also there. When we are not able to access central veins, then utilization of peripheral veins is done to administer nutrients. And the indications are no access to central vein, or a malnourished patient with frequent nil parole for procedures and tests. And if the nutrition is required for a shorter period, then PPN can be administered. As well as in peripheries where central line cannot be inserted or the expertise is not available, then PPN can be resorted to. The limitations are that peripheral sites are more prone to inflammation and infection, and it is a poor choice for long-term nutrition, because the concentration of feed which can be given to a peripheral route is always less than what can be given to a central route. Now, TPN administration should be started slowly, and should be we should allow the blood to adapt to the increased glucose and osmolarity. So it should be started with around 40 ml per hour for first 24 hours, and then be slowly progress to 80 ml to 90 ml per hour for in a week or so. So the rate of infusion and rate of increase of infusion should always be slow, and we should always monitor electrolytes, blood glucose, triglycerides, and ammonia when we are administering TPN, as it was with enteral nutrition. Now, another fact is that the lipid introduction should be also gradual to avoid adverse reactions. When the patient is about to be taken off TPN, then the rate of tapering should always be gradual to avoid hypoglycemia, because TPN gives a high energy diet which induces insulin secretion, and many a times insulin is also administered with TPN. So if we cut off the TPN supply immediately, then the patient is prone to develop hypoglycemia. So if the patient is on TPN, then the tapering off should also be gradual. And we should resort to cyclic infusion of TPN if the patient is to be given for a longer time. This will allow more freedom of normal daytime activity, and it can be used to reverse the fatty liver resulting from continuous infusion. Now, what are the complications related to the TPN? Apart from the electrolyte and other disbalances, the catheter-related complications are added upon by TPN infusion. So they include hydrothorax, pneumothorax, or hemothorax, as well as sepsis and blood clot thrombosis that can be taken care of by proper care of the catheter and regular monitoring. And there are few metabolic or nutrition related complications which I have already stated, which includes hyperglycemia or hypoglycemia. Hyperglycemia when the rate of infusion is higher than what is advised, and hypoglycemia if we taper off the TPN abruptly. There can be dehydration or fluid overload depending upon the rate of infusion. The electrolyte imbalances can be there because TPN doesn't contain all the electrolytes and we do not monitor them, then imbalances are bound to occur. And acid-base imbalance can result in if lipid infusion is more than what is required. Fatty liver is one of the major complications, and bone demineralization can occur by prolonged TPN infusion. Few words on immunonutrition. It has been propagated in patients with major injury and trauma induced or trauma induced by surgery, and it is specifically advised in patients with uh, um, prolonged with advanced cancers, and it has been studied in all these cases. The specific nutrients which have been promoted are arginine, omega-3 fatty acids, and glutamine and nucleotides, and it has been shown that it should be started at least 7 days prior to the 7 days prior to the surgery and continued for 7 days after the surgery. So this has been shown to decrease the increase the immune response in these patients who are immunosuppressed because of the advanced cancer. So indications which have been given by few articles are major neck surgery for cancer, severely malnourished patient, that is serum albumin less than 2.8 gram per deciliter, the patients undergoing major oncological GI surgeries, patients with trauma to two or more than two body systems, the injury severity score in major trauma more than 18 or so, then these patients can be benefited by immunonutrition. However, these are subjected to biggest, larger studies and more RCTs, and then only we can resort to regular use of immunonutrition. Another point on antioxidants, which have been studied in surgical trauma, where depletion of endogenous antioxidants is there. So antioxidant supplement has been suggested to mitigate severe inflammatory response syndrome and nosocomial pneumonia. However, these findings have been limited to few case series and small retrospective studies. Now, at the end, just to um, you know uh, conclude, I will like to go further. I will like to uh, talk about ESPN 2017 guidelines, which which has concised all these points, and it has recommended that the nutritional status should be assessed in all patients before and after major surgery, and perioperative nutritional therapy is indicated in patients with malnutrition who are unable to eat for more than 5 days perioperatively, and patients expected to have low oral intake or who cannot maintain above 50% of recommended intake for more than 7 days prior to the surgery. And how to give if the energy and nutrient requirements cannot be met by oral or enteral route for more than 7 days, and parenteral nutrition should be recommended. And peri or at least post-operative administration of specific formula-rich immunonutrition should be given in malnourished patients undergoing major cancer surgeries. So this was just gist of the points which I've already covered. And coming to the final slides, which will include the clinical approach. So the assessment of a patient should start from the first time the patient is visited to the hospital. So first OPD assessment is the most important, followed by admission assessment at admission in the hospital. So usually in government hospitals, between OPD to admission, it is 7 to 14 days. So if we assess in the OPD, then these things can be optimized very well by the time the patient is admitted to the ward. And what we should assess has been very well described in the previous lecture. I will just reinforce them, that we have to assess the weight loss, the onset of disease, the body mass index, the peripheral presence or absence of peripheral edema, the any signs of vitamin deficiency, the triceps skin fold thickness, and anticipated post-surgical nutritional requirements. So if any of these things suggest that the patient requires nutrition therapy, then we should always calculate the total energy requirement, the protein requirement, and fat requirement as per the formulas I have shown, and we should decide on the route of nutrition. So if the patient can take orally, then we should encourage that orally. If not, then either enteral or parenteral nutrition should be resorted to, and we should always monitor the specific things regularly to avoid any electrolyte imbalance or the complications of enteral or parenteral nutrition. And the most important indicator among them will be albumin. That should be checked after 2 to 3 weeks, and if it is increasing, then the patient can very well undergo a safe surgery. So, my concluding remarks will be that malnutrition is significantly affects the outcome of surgery, and identification of malnourished patients and appropriate initiation of nutritional therapy should be done prior to on an OPD setting and prior to admission, so that the post-surgical discharge and recovery is optimal, and enteral nutrition should always be preferred over parenteral and formula feeds for patients to optimize their nutrition. Thank you.